Ready.
Cool.
So, hello everyone. As you know by now, my name is Rafeh. I am a fourth-year medical student at the American University of Beirut Faculty of Medicine. And I'm really interested in neurology and in specific behavioral neurology. And I want to talk about the therapies for this disease that is notoriously difficult to treat and futile in terms of management. I'm going to mention the therapies that have been developed in the past, what's going on in the present, and look forward to future therapies. So I'm going to go through the burden of Alzheimer's disease. I'm going to present the theories of the pathophysiology of the disease. And in doing so, I will present the pharmacological targets. I will also present to you the therapies that are in the works and go over one non-pharmacological therapy that seems to be promising. Okay, so to begin with, anyone who has met a patient with Alzheimer's disease knows how debilitating and crippling this condition can be. But it's not only debilitating to the patient, it's debilitating to the family and the caregivers. I mean, the families with family members who have Alzheimer's disease are crippled psychologically and physically speaking, especially when the patient gets to the end stage of this disease. However, if we view it as a public health problem, it is also a big deal. 43.8 million individuals are affected by this disease worldwide, and it's growing in number due to the aging population. In 2015, it was the sixth most common cause of death in the US, and this is just talking about death and not mentioning the impairment and productivity that these people incur. Now, it is also estimated that this is an expensive disease because we have to think of the public health system as well, in addition to the individual. And it's estimated in 2020, it has cost the healthcare system $305 billion. And as the population continues to age, it will continue to cost more and more. So this is why it is very interesting for us to find a cure for this disease. Now, in order to develop targeted therapies, one must understand the pathophysiology behind Alzheimer's disease. And I will present to you this figure that I got from a review by Panza et al. In Nature's Review. Now, first of all, the main problem, you can see my mouse, yeah. The main problem is this transmembrane glycoprotein known as APP, amyloid precursor protein. As you can see, it has an intracellular component and the glycoprotein and the carbohydrate component sticking outside. Now, the problem is not in this protein, glycoprotein itself. The problem is that when it gets degraded, and it does so by three enzymes known as secretases. There's beta secretase, known as BASE, and gamma secretase. And there's also alpha secretase that is not implicated, that is not shown in this figure because it's not implicated in Alzheimer's disease. Now, beta secretase and gamma secretase cleave this amyloid precursor protein at different areas, generating different amyloid beta peptides. And usually the peptides that are generated are 40 or 42 amino acids in length. Poorly soluble. We generate more and more of this amyloid beta peptide. They begin to aggregate together, creating monomers, oligomers, and eventually they create this plaque. And this plaque is damaging to neurons. It disrupts the neuronal cell membrane. It creates inflammation in the brain. And once inside the neuron itself, it ends up disintegrating the microtubules and creating tau protein aggregates, which have also been shown to be implicated in this disease. However, despite this well-elucidated pathway or pathophysiology, the majority of targets, as we will see, the majority of medications that target these components of the pathway are not effective. And in fact, Alzheimer himself, when he first saw the evidence and he first came up with this disease, he did not think that the amyloid plaques are are causing the cognitive impairment. He thought that they are a result of toxicity to neurons and not the primary cause. Now, this theory is interesting. Of course, we really do not have much evidence to support it or to support the theory cognitive deficit. But given that the therapies that act on this pathway are not very helpful, we need to give some thought to what Alzheimer initially thought of. Now, it is interesting to note that 44% of elderly individuals with normal cognition have amyloid plaques in their brains. So this is also supportive of the fact that Alzheimer may have been correct, that this is not the primary insult, that maybe there is a nerve damage that happens at the beginning and causes this plaque deposition. Now, that being said, and given this pathway, I will go over some of the mechanisms that we use in order to target it. First of all, there's the active immunization against amyloid beta peptide. Now, this was very interesting to me, and I'm sure that it will be quite interesting to others to know that there was a vaccine that was developed in order to target these amyloid beta peptides. Now, that would be a dream come true, of course, but as I will mention later, it was not effective. Now, in terms of the vaccine itself, it targets the amyloid beta fragments that are conjugated to a carrier. So you inject these fragments and there's an immune response to these fragments. And what they hoped, so what the researchers hoped while they were developing this was that you'd have this immune response against these fragments and you'd clear them up, and then you will not have the plaques anymore, and thus you will not have cognitive impairment anymore. The other mechanism by which we can target this pathway is passive immunization. And this is using polyclonal or monoclonal IgG antibodies against amyloid beta peptide. And this is intended for use in patients at high risk of Alzheimer's disease or in patients in early Alzheimer's disease. Now, the third mechanism that we may use is inhibiting the secretase that cleaves this amyloid precursor protein to create the amyloid beta peptide. Now, let's see how these three ways by which to target this pathway fared in clinical trials. Now, here I present to you the history of amyloid plaque targeting vaccines. So this is the active immunotherapy. In 2002, the first vaccine was created, and there was much hope that it would provide the cure or a preventative measure for this disease. Now, basically, it was an amyloid beta peptide conjugated to another molecule in order to enhance the immune response to it. And researchers were pleased to find that the burden of amyloid plaques was reduced upon imaging. And also when they took plasma samples, they realized that the burden of the Alzheimer's disease had been reduced. However, 6% of patients developed meningoencephalitis, since we must remember that we are utilizing this vaccine to create an immune response against the brain itself, against the plaques which are in the brain. So this developed in 6% of patients, unfortunately. In 2013, they came up with a similar concept to the first vaccine called vanutide. And here we had a short amyloid beta fragment linked to a diphtheria toxin. And this vaccine fared well in terms of not having much adverse reactions. Not many people developed meningoencephalitis. However, there was no benefit clinically. The cognitive impairment did not decline. And as we have seen in the previous vaccine, also the burden of the amyloid plaques was decreased. So again, this shows us that amyloid plaques itself may not be tied to the cognitive impairment. In 2014, there was yet another vaccine called the CAD106 vaccine. And this was more promising because they gave multiple doses of this vaccine. And as they noted, they were giving more doses, and the serology, there was more IgG developed against this amyloid beta peptide. And as they realized that there's more IgG, they noticed an improvement in symptoms. However, this was not statistically significant. So it's a bit of hope, maybe with adjustments to the study design, recruitment of more patients, it could work. And this is still currently under study. Yeah. Okay. Sorry. Okay, now we move to the next type of therapy, which is the passive anti-amyloid beta therapies. So basically you give monoclonal or polyclonal antibodies against the amyloid beta peptide. There are 5 drugs that are currently in clinical trials, and unfortunately, the data does not show much benefit, and they have adverse effects that are very serious, including vasogenic edema and brain microhemorrhages. There was only one study that showed promise, and that was on solanezumab. It was the Expedition trial, which showed reduced cognitive decline in mildly affected patients. However, this was a subgroup analysis of the initial trial, and we need to recruit more people in order to understand if this is indeed significant. And this is what's being done right now. There are more ongoing studies on this class of drugs, including the DIAN-TU study. It's on 3 drugs, solanezumab being one of them, gantenerumab being the other one, another one of the same class, and atabecistat, which is a secretase inhibitor, being the 3rd one. It's going to be completed by 2022, so let's hope there will be some promising results. And there are other studies that are currently going on. Many of them will be completed between 2020 and 2025. So hopefully we'll achieve some response, but it does not look promising based on previous data. Now, the 3rd class of drugs that I want to discuss are the beta secretase inhibitors. And before I discuss this class, I just want to note that beta secretase is a very important enzyme, both in the central nervous system and outside. It has other functions, including cleavage of amyloid precursor protein. And it's involved in axon guidance, in neurogenesis, in neuronal network functions, and myelination. So honestly, it was expected that this might not work much, but of course, everything has to be tried clinically. And indeed, clinically, it showed that there was a rapid reduction in whole brain and hippocampal volumes once this drug was administered. And this led to even worse cognition. So unfortunately, it was not effective. And as with the other drugs, it had a decrease in the plaque markers of Alzheimer's disease, but it was not effective on cognition. In fact, some of these drugs made cognition worse. Okay. So as you can see here, now this table is just meant to show you the scale of the clinical trials that are going on. Now, everything with a blue mark next to it is still currently in clinical trials. So we have not given up on these drugs. And if you can notice here, the CAD 106, this is the vaccine. It's still currently in phase 3 trial. So we're hoping it would work. But yes, there are still many trials going on. And you may ask yourself, why do we still have clinical trials on these drugs, even though they've shown us time and time again that they do not work, they're not effective? Well, when developing a drug, there are modifiable things that you may change in order to make a clinical significance. For instance, giving a higher dose, administering it differently. For instance, for the vaccine itself, maybe you need 3 booster doses, 4, 5. We don't know that because it's still in development. And also you may modify the study design, including adding more people to the study, adding patients in earlier stages of the disease, making it a preventative therapy in people who have, let's say, the autosomal dominant mutation. So this is why the studies are still going on, and there are still modifications in the design of the studies in order to maybe hopefully produce a difference. Now, after, I know we've just discussed something that is not very hopeful, but I just want to share with you the currently available pharmacotherapies that I know a lot of us are familiar with. Now, these help with the symptoms mildly, but they are still there and may provide some benefit, including the NMDA receptor antagonist memantine. It's been used widely for the treatment of Alzheimer's disease, and it produces some symptomatic benefit. It's also being studied right now for the treatment of other disorders like obsessive compulsive disorder. But yes, it seems to be a promising treatment. And we may also use acetylcholine esterase inhibitors, since we know that in Alzheimer's disease patients, the levels of acetylcholine are declined. And unfortunately, there have been no new drugs approved since memantine in 2003, despite extensive research into the disease. Now, moving on to a more hopeful note, and even though the pharmacological therapies have not been that effective, there is a non-pharmacologic therapy, so much less side effects, that may be effective, and this is the neurofeedback therapy, whereby you conduct a quantitative EEG to test the brain waves of the patients in every region of the brain, and you see where the deficit is. And actually, multiple quantitative EEGs carried out on Alzheimer's disease patients have shown that they have greater amount of theta wave activity than the normal elderly population. And we can target this theta wave activity through neurofeedback therapy and increase it in order to better their outcomes. Now, unfortunately, there have not been large-scale trials done. There was one trial done on 10 patients that showed improvement in cognition, but the study size is really small and we need more people recruited. There was another study that was going on by the NIH, but in the middle of the recruitment process, COVID broke out, so they terminated the study. So hopefully it will resume after COVID is over. And yeah, basically, I want to just explain a bit how this neurofeedback therapy works. So basically, we have sensors placed on the skull just to detect the different brainwave activity. And we know which areas have a difference than the normal population. Now, this activity is sent to a computer system that analyzes all these waves and then feeds back directly into the brain again in order to modify these waves and make them more normal, normalize them, and this produces a cognitive benefit later on in the patient. So that's the theory of how it works. And with this, I am done. Thank you so much for listening. I hope you learned from my presentation. And does anyone have any questions?